Welcome, everybody. It's time for Health Talk here on KGVO, brought to you by Community Medical Center from day one. I'm Peter Christian, and joining us here in studio this morning, we have Dr. Gary Harvey. But first, I got to say hello to my co-host, John King.
Good morning, Peter.
How you doing, partner?
I'm good.
All right. How was your weekend?
It was good. Went hunting. Saw a lot of ladies. No men.
Really?
There were no bucks, no bulls, just a bunch of cows and does.
Okay, which very...
Which kind of segues us into the OBGYN, right?
I'm not sure. Dr. Harvey's saying, what? Say what?
I did get 3 wardens pulling me over. We'll talk about that later, though.
All right. Anyway, all right. So,
I'd
Dr.
rather talk about hunting anyway.
Yeah. Dr. Gary Harvey joining us here in studio.
Thanks
How
for
are
having
you?
me.
Good to see you.
Very good.
All right. So, tell us a little bit about Dr. Harvey. I know you're an OBGYN.
Yes, sir.
Obstetrician gynecologist.
Yes, sir.
Did I get that right?
Yes, sir.
All right. So tell us a little bit about you and your
I
practice.
got to first say hello to all of Dr. Pitt's patients. He wanted everyone to know he taught me everything I know. But I think I did have a pretty good handle on the English language before I met Dr. Pitt. But
okay.
He's a good man and now retired.
Yeah. And I know that when doctors retire, that can be a bit of a sticky wicket because especially something as deeply personal as an OBGYN,
Yes, sir.
you want to make sure that whoever you're handing off your patients to is someone that you can trust. Obviously, he trusts you.
I think so.
There you go. That's good. So tell us a little bit about your practice, because I know that one of the things we wanted to talk about today is some technological things that have come forth in your practice that have really, really improved your patients' lives.
Well, I do practice general obstetrics and gynecology, but my real passion is robotic pelvic reconstructive surgery or robotics in general. Robotic surgery has been around since 2005. We've been doing it at Community Medical Center since the spring of 2011. And I personally have done about 500 procedures. And it's really been a tremendous advancement in pelvic surgery, especially pelvic reconstructive surgery, being able to offer patients what is now well recognized as the safest surgical option in the management of most pelvic surgical issues, especially pelvic reconstructive surgery, where at one time Drs. Pitt and I and Dr. Ferguson all performed these procedures through a large abdominal incision, where now we can offer the same treatment through small incisions, which allows patients to recover more quickly. They have less surgical pain. They have a rapid return to recovery, leads to less bleeding, infection, injury. And again, I think most importantly is just the safest option we can offer patients. I think if I was going to have surgery, I'd be asking my surgeon, what's the safest option you can offer me so that I can walk away with a good result? And this is really it.
So what sort of things are you using the robot to fix, like fractures? And are you putting pins to keep bones together or what?
No, I'm a gynecologist, not an orthopedist, but we don't use pins. We do use some permanent structures, sutures, and mesh, but the mesh we use is not the mesh you hear on the news, as I tell patients, not the mesh you hear on the news and the lawyers and the lawsuits and those things. It's a much safer option when we offer it robotically. But reconstructing a woman's pelvis, childbirth itself is horribly destructive to the support structure of a woman's pelvis. And as I tell patients, I really have to be thankful for childbirth. We have to thank God for that and so many other things. And that's why I say, Jeff, come over here and hold my hand so we can pray and be thankful that childbirth exists. Because as an obstetrician gynecologist, it's really what I do. I see both ends of it. I enjoy obstetrics. I really enjoy the relationships we develop with patients. But women who have undergone normal vaginal birth often suffer loss support to their bladder, their rectum, their uterus, leading to symptoms like incontinence and bulging. And as a sequelae to childbirth, it's something we can manage surgically now and reconstruct their pelvis.
Now, before all this, doing that type of surgery was, as you had mentioned, it can be very invasive. You have to do a large incision. You have to, and whenever the body is opened up in that way, even though you're using the best sterile conditions and all, the best practices,
yes, sir,
that things can go wrong. But in this robotic surgery, whenever you reduce the amount of if you will, invasiveness into the
yes,
whole cavity there,
yes,
then it's better for the patient.
Yes, sir. That's why we call it minimally invasive surgery, because it is much less invasive than it used to be. And that less invasive approach, as I said, leads to a safer operation, less risk. And the other thing is, I think many times a deterrent to surgery is a surgical pain. What would you experience? if you're looking at an operation, if you're going to have hip reconstruction and a large incision, how is that going to hurt? So being able to offer patients a procedure where they're going to recover very quickly, a few days of opiate therapy, pain medication, and most within a few days, a week are off pain medicine and largely functional.
Let me ask you this. How long after childbirth does this surgery take place? Is it something that you do right away after the baby's born, or does a mom come make an appointment a couple of weeks later after they've recovered a little bit from the childbirth, or what?
Yeah, great question. The vast majority of the time, it's many years after they've given birth. Really what we're dealing with is a hernia. It's a herniation, loss of support to their uterus, bladder, rectum, etc. And it's a slowly progressive problem for the vast majority of women. But I've seen women in their 20s with incontinence and prolapse, and I've seen women in their 90s. But the vast majority, probably average age is about 60 or so.
Wow, okay.
I'm really curious about something. My nerd is going to show out here, but the Institutes of Health Metrics and Evaluations, I think I got the acronym right. They did a study back in September, or published this study, and it was about maternal mortality, parents or mothers dying when they're giving birth. And the United States is like one of the only countries where the trend line is increasing, more mortality for women giving birth, as opposed to most of the other nations where it's been on the decline for 15 years or more. I guess my question for you is, what do you think might be behind that trend? And how can women protect themselves during childbirth?
Well, a mom dying in labor is a very rare problem, even though statistically it may appear to be higher here than it is in other places. And at Community Medical Center, we have a policy against that, so we don't allow that. And I suppose there are many reasons that happens, but it is still a very rare event. I have personally never seen a mom die in pregnancy.
Well, that's very comforting. So when it comes to giving birth and everything, the inputs, if you will, the woman's health and everything that go in. I mean, do you work with women before they're going into labor, or are you mostly just reconstruction on the other side?
No, in obstetrics and gynecology, again, I do obstetrics, which means we take care of moms during the course of their pregnancy, through the delivery, and then thereafter for a brief time, typically 6 weeks. And then the gynecology part of it is treatment and management of diseases of the female genital tract.
I can't imagine a profession where you become more part of a family than being an OBGYN, because from the very outset, once the woman believes she may be pregnant, comes in for a test, she's pregnant, okay, got to go in for all the prenatal stuff, and you do that as well? That's part of your practice? Okay. So tell me what that's like, of so many people that have, like, really you're adopted into the family. You become a very essential part of their family.
Yeah, that's, again, one of the things I've enjoyed most about the field of obstetrics is getting to know these patients and as you said, really become a part of their lives and getting to be so close to them. Some more than others, but many times patients are very, very close. And so it's a wonderful thing.
You bet. Well, we're going to take a quick commercial break. We've got phone lines open, and you're already getting calls, Dr. Harvey. So Dr. Gary Harvey joining us here in studio, OBGYN, and we will continue with Talk Back, and he's willing to take your calls and questions on a general nature when we come back in a moment. Okay, we are back on Health Talk. 721-1290 is our number, 1-800-568-5309. We're also accepting questions or comments on our Facebook page for Dr. Gary Harvey, OBGYN at Community Medical Center. So we had a call-in question.
That's right. So Allie called in, and she was really curious about what she called HRT, or hormone replacement therapy, and was wondering if you could talk a little bit about what the latest is when it comes to HRT.
Well, I think hormone replacement therapy still remains as one of the most controversial subjects in gynecology. We have gone through every permutation you can think of, from its life-saving to its life-threatening. The last large study was published in July of 2002 called the Women's Health Initiative. And in that particular study, they appeared to have found hormone therapy increased the risk for heart disease and breast cancer, but within 6 months, most of that was largely refuted. But nevertheless, there have not been any large multi-center trials since then, despite it being 14 years. And I suspect it's in part because the manufacturer of Prem and Wyeth that offered all that hormone for that study was largely euthanized by those results. So there's pharmaceutical companies aren't jumping forward to give up their hormone therapy for study. But there still are occasional smaller studies looking at the relationship between hormone replacement doses of estrogen and risks and benefits. And I think there are clear benefits, especially for a perimenopausal woman. It is the most effective form of therapy in relieving symptoms, but it may also reduce the risk for heart disease, osteoporosis, bone fractures, Alzheimer's, dementia, colon cancer. But like most things, there's
Reduce
benefits.
or increase the risk?
Reduce the risk.
Oh, wow.
The Women's Health Initiative, there were about 5,000 women in that study who were perimenopausal. And
Now, forgive me, what does that mean?
they're
Perimenopausal.
around the time of menopause. The average woman in that study was 67 years old. And what they did find in a previous trial had also documented that when you offer women remote from menopause hormone therapy, you may increase the risk for cardiovascular events. So the previous trial was called the HERS trial, and the Women's Health Initiative demonstrated that again. But the small subset of women who were in their early 50s who had recently gone through menopause and were offered enrollment in this study because they didn't have symptoms, there was actually a trend towards a reduction in heart disease.
Wow.
So some benefit, but like most things, there's risk. It probably does increase the risk for breast cancer slightly, but it can reduce mortality because we're better able to identify women with breast cancer by mammography for women on hormone therapy.
So basically, that's one of the deals where you would sit down with someone. They would come to you with these questions. You would lay out the surveys, lay out what the studies have done, and say, you know what, when all is said and done, it's your decision, right? Is that how that works?
Well, we certainly hope that we're able to provide patients with information so they can make an informed decision for their health. And unfortunately, in this day and age, there's so much access to health information on the internet and such. And as I tell patients, some of that's even accurate. So
well, you answered that last one pretty crazily awesome. I've never seen someone actually cite the year of the study. So I thought that question was from left field, but you handled it well.
Very good. Grab your headphones because we do have a caller on the line. This is Lucille. Good morning, Lucille. You're on with Dr. Gary Harvey. Hi.
Hi. How are you today?
Very good.
What's up?
I have a question. I have been diagnosed with rectal prolapse, and I wondered if you do that kind of surgery at community.
Well, if it's true rectal prolapse, which means there's an aversion of the rectum to the anal canal, then that's an operation that's generally done by a colorectal surgeon. I think the nearest is Spokane. It could be wrong.
I have an appointment in Spokane, and when I heard you this morning, I thought I should check to see if it could be done in Missoula.
Not that I'm aware of. Some patients who come in reporting rectal prolapse are actually describing a rectocele, which is a defect in the back wall of the vagina.
Okay.
If that's consistent.
All right. Well, you've relieved my mind because I really didn't want to go over to Spokane if I could stay here. Thank you very much.
Okay, you're welcome. Good luck.
Thanks, Lucille. Best of luck to you. So one thing I was interested in asking you about, Dr. Harvey, was being the age that I am, I have a lot of female friends who have gone through various problems after childbirth, as you mentioned, in the years following. And they've had surgeries, and they've had some real complications. Is it possible, from the damage that was done, not necessarily done by the surgery, but perhaps that they didn't have the technology that's available today, to repair some of that by using the robotic surgery?
Well, I think what I'm offering is different than what most gynecologists offer. Finishing my training in '92, virtually every gynecologist was trained to repair prolapse of the bladder, for instance, vaginally, making an incision and plicating, which really doesn't address the defect that creates that prolapse in the first place, which leads to high failure rates. There was a study just published that documented even within 2 years of more than 50% anatomic failure rate when the procedure is done that way. I haven't done that procedure in more than 20 years because it just doesn't work. When you are offering a surgical remedy for patients who's ineffective, you end up with a lot of unhappy patients.
Sure.
So many times I'll have patients come in and tell me they've had surgery 2 or 3 times before, and they keep having the same operation that just doesn't work. It works for a while, but invariably, because you're not actually reattaching the defect to its normal anatomic site, it just comes back.
But can you fix that with the robotic?
Yeah, you can still fix it.
You can.
Yeah.
Okay.
Reconstructive surgery is not perfect. And not every patient I operate on is entirely thrilled, but prolapse occurs for really largely 2 reasons. The tissue stretch and ligaments break. Once you get to the stage where things are stretched, it's very difficult to remedy that. But the vast majority of patients, I saw 3 on Friday who were glowingly happy with their results, and you hope that long-term it remains that way. But reconstructive surgery, again, is not perfect. If you're visiting your friendly neighborhood orthopedic person about a new hip, it's probably not going to be the one he's replacing is not going to be the one that God gave you. So you hope that it's good, but it's probably not going to be as good.
Okay, we're up against a break. 721-1290, Dr. Gary Harvey joining us here in studio. We have 4 lines open. If you have a question for him, he's here willing to answer it for you. 721-1290, we're coming right back. And we're back. This is Talkback, 721-1290. Actually, it's Health Talk. We're going to get to Talkback here in a few minutes. Talking with Dr. Gary Harvey. He's an OBGYN at Missoula Community Medical Center. And for those of you who may have just joined us, Dr. Harvey is really, really sold on the whole robotic, the Da Vinci. It's called the Da Vinci system, right?
Yes, sir.
Okay. And how did you get acquainted with the Da Vinci system and get started doing robotic surgery?
Well, we acquired our robot. And the robot is called Da Vinci, and it's made by a company called Intuitive Surgical in the spring of 2011. And I think I, along with a lot of older physicians, were reluctant to change, but I had my own personal issues that kind of motivated me to do this. I was starting to have headaches, just bent over in the operating room for hours, but I was still reluctant, and I had an occasion to go to Colorado to see a gynecologic surgeon there, John Crane, operate, and it was just amazing to watch what he could do with a robot. And that's the way Intuitive Surgical wants surgeons to approach it, is very slowly, see if it's right for you. And I think myself, along with physicians like Dr. Tim Richards, have really gravitated towards the robot and recognize it's a much better option for patients. It takes a little more time, and it's a little more effort on the surgeon's part to do this, but when you see the benefits your patients receive, it really makes it all worthwhile.
What percentage of your surgeries are you now using the robot for? Is it most?
Virtually all. I've, in 5.5 years, have done 2 or 3 open procedures. So virtually everything I can do with a robot.
Wow.
Even patients with significant pathology, previous surgery, a lot of scarring, large masses can all be done robotically. Now,
the whole idea is that the incisions, as opposed to a large incision, are very, very tiny. Can you explain how that works? Yeah.
Well, they're, depending on the technique you're offering, it generally, for most, especially for advanced pelvic surgery, requires 5 small incisions. 3 of them that I use are 8 millimeter. I like to use a 12 millimeter port for the scope. It just gives you better light. And then the needles and mesh and such we use pass through a 12 millimeter port better. But going from an 8 to 12 they're still very small incisions. And many times, surprisingly, the patients don't even recognize those incisions. They may have some pelvic pain, but it's not incisional pain like the bigger incisions used to create.
We have a minute left. Believe it or not, this half hour has flown by. So give us some contact information for your office, Dr. Harvey. So if women out there or their families are saying, hey, this is something we need to look into, what do they do?
Well, our office is at Community Medical Center, Building 3. And we have a website, montanaroboticsurgery.com, and our office number is 728-4292. So We try not to hide. We're here to help.
Well, our Facebook page, Justin says, my wife has an appointment with him this afternoon. He caught all 3 of our kids.
Well,
Oh, perfect. I hope another one's on the way.
Get that catcher's mitt ready.
there you go. All right. Doctor, it's been a pleasure. Thank you
Yes,
so
sir.
much
Thank
for
you.
and I loved our off-air discussions too. It's very good. If people only knew.
The dark sides of KGVO.
Anyway, you have a great day, sir, and we look forward
You
to
as
seeing
well.
you again. All right,
Thank
thank
you.
you. Dr. Gary Harvey, our guest on Health Talk this morning. Stay with us. Got a whole hour of open phones on Talkback coming your way in just a moment.
It's nice to meet you.